Hello, Montana, and hello, world. This is Chris Hislop from the Montana World Affairs Council, bringing you another episode of Connect Montana, where we bring the world to Montana and Montana to the world. This week, we're talking about European healthcare and learning a little bit more and separating fact from fiction on things we hear about the provision of healthcare in Europe. If you missed our show on Tuesday, we had Katarina Kirk from Denmark asking us whether we thought it was actually socialized medicine or, as she suggested, democratic medicine. Very interesting point. Today, we're going to take an even deeper dive with our guest, Brian Fitzgerald. Brian Fitzgerald joined Beacon Hospital in Dublin as Deputy CEO from St. James Hospital, where he was the Chief Executive and Director of Finance. He is a fellow of the Association of Chartered Certified Accountants and holds an MBA from UCD, Michael Smurfit Graduate Business School. He also holds the position of Adjunct Assistant Professor at the Centre of Health Policy and Management at Trinity College Dublin's School of Medicine. Brian, you are very welcome here to Montana and to the world. Thank you so much for joining us. I wonder if you could start out by giving us maybe a broad understanding from your perspective on European healthcare.
Thank you, Chris, and thanks for the invitation. I hope you can hear me okay.
Yes.
Yeah, I just introduce the background is a view of Dublin Bay and Dublin City from the Dublin Mountains. So hopefully that and greetings to everybody. It's 7 p.m. in Dublin. It's getting a little dark at the moment, so I'm looking forward to getting home soon. So I'm going to share my screen with you, if that's okay.
Yes, go ahead.
Can you see that, Chris?
Yes.
Is that okay?
Yes.
Yeah, I'll just put on the slideshow now. 1 second, please. So, not dissimilar to your colleague from Denmark, I just wanted to touch on a few issues of context that probably will give you guys some understanding of why the healthcare system in Europe is somewhat complex and different jurisdictions adopt different principles. And the background is social. Well, your colleague says democratic healthcare. There is a social context to this in that the various regions in Europe depict how healthcare has developed over the last century in Europe. So you've got the Nordic culture, Anglo-Saxon, the Bismarck and continental side, and Mediterranean, Southern, and then on into Eastern Europe. So you can see the various countries that are associated with each region. And separately, you've got the concept of social security and where that is high in some regions and some countries and low in other countries. That all feeds into the flavor of healthcare in Europe. And the last thing on this slide I'll talk about is employment. There's high employment, as you can see, in Nordic to continental countries, and then low unemployment, which again feeds into why governments play a social involvement in healthcare versus perhaps more insurance-based systems. And one point to note, just at the bottom of the slide, we do have a thing called the EU Cross-Border Directive, which has been in place for about a decade, which is encouraging citizens where there are waiting lists, where there are unmet need, to find that need in other jurisdictions. And that's starting to create more traction where patients are moving between jurisdictions in Europe, notwithstanding Brexit, and I'll speak about Brexit in a moment. So what I'm going to touch on is the governance, the financing, the delivery, and the human resource side of the building blocks of EU healthcare. On the governance side, it's worth pointing out again, following the flavor of the social context, you've got the concept of decentralization, partially decentralized systems, operatively decentralized, and then centralized but structured at territorial level, and then centralized solely. So if you look at the flavor of this, when you look at the likes of Denmark and Austria, they're very much centralized systems. Ireland has become somewhat centralized, although we have adopted what I would call similar to an NHS model. We call it the Health Service Executive in the last 10 years or so. And that was the government trying to politically decentralize decision making. It's still in its infancy. In the UK, for example, they've operatively decentralized through the NHS on down into certain health trusts. You may have heard of these NHS trusts, and they manage certain regions. You take the Greater Manchester area now, where you'll find a trust which is managing both hospitals and primary care. And then, of course, you got centralized but structured in the likes of France, and then purely centralized models that you'll find in Cyprus and indeed in Finland and Scandinavia. So just to give you a flavor of the different types of governance. At the top of the slide, just to say, if you can see that the healthcare budget in Europe is over 1 trillion now. It's exceeded 1 trillion and will exceed that even further with COVID. And that's about 10% of GDP. The major financing sources are found with general taxation, and I'll talk a little bit about that in a moment, and contributions from health insurance funds. So to give you a flavor, so in Germany, most of the healthcare is provided through social insurance funds, distributed through commercial models throughout the country, both public and private. In Ireland, for example, about 10, maybe 12% of the overall health spending is generated from health insurance contributions directly from citizens. So to give you a flavor, and likewise in the UK, the health insurance side and indeed private funding of healthcare is beginning to get more traction. Okay. So the predominant systems, as we call them in Europe, financing, there's the Beveridge model, public financing by general taxation, the Bismarck model, predominantly in the center of Europe in Germany, public finance based on compulsory insurance. So in the German context, you typically, as a citizen, pay 7% of your gross income into a health insurance fund, and that's matched by your employer and then distributed through a central insurance-based system. Private financing is becoming more of a thing, and we call it kind of voluntary stroke commercial insurance, and then occupational finance, where you have big employers who will have their own insurance funds, and historically public sector bodies like the police system will provide insurance for their employees. Just to give you a picture of percentage of GDP, it ranges in Europe, believe it or not, between 6.3 and 11.3 for all sorts of reasons. So you can see Germany, all schemes are 11.3%, but the compulsory insurance side, the government run compulsory is 9.5%, and voluntary, in people who pay voluntary insurance, private insurance, and indeed self-pay, 1.7%. Just to highlight Ireland in this, we've an unusual situation that we have such a high foreign direct investment into the country. So all of the tech companies and the pharmaceutical companies who generate a huge amount of wealth and income in the country. So our GDP is our GDP can be quite skewed in that context. So it looks low at 7.2%, but if you look at gross national income, that's the income we generate within the boundaries of the Republic of Ireland. We're quite high. We spend about 11.1%, and again, there is the flavour here of more and more voluntary contributions from citizens through either private health insurance funds or their own out-of-pocket payments. On the service delivery side, we've got a couple of models at play in Europe. One is the public setting and indeed the private setting. So for example, in the public setting, you'll find that very much in Scandinavia, very much in those countries that have high unemployment and are very much relied on the state, more and more on the private side, more wealthy countries with social insurance contributions and with national health systems, Germany, Netherlands, UK. Ireland is a bit of a mixed bag in that context. And when you look at gatekeeping prevalent in countries with national health systems, you can see that primary care providers, there's different obligations. So for example, in Sweden, there's no obligation to register as a primary care provider in any structured way. Yes, but it's compulsory in countries such as Italy and Portugal and Spain. The referral source, when we look at it to secondary care, onto hospital or acute care, again, there's no obligation to have a referral in, for example, Austria, but it is compulsory in the UK and Hungary. And when I talk about financially encouraged, say, in the referral side, you find that that access to secondary care is pretty much now prevalent in these countries based on the patient's ability to pay or have health insurance to pay for them. So you find in these scenarios very much an unmet demand versus supply, and the flavor that we see in the Western world, and no system is perfect anywhere, we see greater waiting lists. So if you were to look at waiting list statistics across Europe year on year, notwithstanding COVID, they're increasing exponentially. On the human resource side, this is again a flavor. I'm sure you're experiencing this in the US. Regulations of physicians. Firstly, no restriction in Belgium, Greece, for example, regulated publicly funded providers in Australia, Germany, and indeed Sweden and Ireland. Performance pay in Europe, and I've studied quite a lot of your systems in the US. So I was over in Colorado not long ago, in Denver with Kaiser Permanente. There's actually very few examples in Europe of where performance pay is linked, which is, I think it's something that is akin to what's happened with the social context of Europe, and where it is starting to find traction. For example, in Germany, they're setting up single specialty units, orthopedic units, cardiology, cardiothoracic. They're beginning to get great traction in efficiency and encouraging performance pay, but it's slow to take off. Third-party payers in the system that are there, particularly insurance companies and then social insurance companies, people would argue that they're to improve the quality of care. There's a question mark over that. And now we're beginning to see policies to address HR distribution. So this concept of having the national center and attracting all of the talent, jurisdictions are trying to grapple with that now and try and get a more geographical spread of talent. And then, of course, we're all experiencing human resource shortages. So now these governments are starting to address how they attract nurses and doctors, in particular, how they retain them. And that's beginning to get a bit of traction for those people who are involved in the HR side of the US. So very briefly, characteristics of some of the systems. The UK, and forgive me if your colleague has addressed some of these already earlier in the week, free at the point of service, and the funding I've talked about, general taxation and national insurance contributions. And there's a separation there of secondary and primary care. In the Netherlands, market-based, 99% compulsory insurance coverage, and service provision is classified as private. In Germany, decentralized to landers or states, universal coverage, statutory and private insurance. And you can read some of that slide for yourself. And Denmark, decentralized, a significant role to play by regional and local authorities, free at the point of care service, universal coverage, public financing, and national and local taxation mixes to provide that public provision of care. So just to give you a flavor of the characteristics of some of the jurisdictions. So really, in conclusion, I mean, we've headwinds, obviously, all of us, COVID notwithstanding, and for Ireland in particular, Brexit coming at the end of this year. You've got to understand the social context of healthcare in Europe, and that feeds into multiple and mixed governance, delivery, operational and finance approaches. And on the financing side, we really are facing huge challenges even before COVID, with the fairly significant increase in cost of healthcare, and how governments are trying to grapple with that, both from central taxation and then looking at shifting more of the burden to citizens. So financing, taxation, social insurance, variations, country, I mentioned that. The financial HR challenges, I touched on that, but they are significant now in Europe as they are in other systems. There is definitely more of a move to EU integration on the cards for healthcare. I've mentioned the European directive on patients can access care in different jurisdictions. There are central groups now in the Commission and the Parliament in Europe starting to ask questions about taxation, corporate taxation, and equally, what are we going to do about healthcare and how do we uniformly approach healthcare over the next number of decades? And one to watch for is privatization. So if you look at the London example, they estimate 50% of the care in London now is provided privately. So for example, I visited the Mayo Clinic, have opened in Portland Place, an ambulatory centre, to contrast with the Cleveland Clinic, who are building a hospital in London. And the Mayo Clinic are planning to see about 20 patients a day in this clinic. And they were booked out when I visited before Christmas until June this year. Obviously, COVID has interrupted that. But it was incredible what they were able to charge in the context and the demand for the service, which, as I say, was an ambulatory by nature. It wasn't in any way sophisticated. So I'll stop there because I know we're all on the clock here. And thank you.
Thank you so much for that, Brian. I wonder if you could stop sharing your screen for a moment, and then we'll get back onto the. There we go. We'll get back onto the big screen here. And I am, okay, very good. So Brian, it's not easy to cover the entirety of a European healthcare system in the short time that you did, but thank you very much for that really broad overview. I think what immediately comes to mind for most of the participants here in America, and certainly for me, was this variation. I mean, you referred to it as multiple and mixed across, the financing, the governance, the HR, all of these things. I mean, I think oftentimes the American tends to think it's all one thing, but clearly there's a huge variation, um, and which is going to make the following question very difficult. But I'm gonna give it to you anyway to see if you can maybe enlighten us a bit, just in terms of a comparison, if you will. If we look at our healthcare systems, comparing, I think, three elements that are primarily, what come to mind, which is the cost of care, the access to that care, what can you get and when can you get it, and the quality of that care. I mean, these are major concerns for anybody accessing any healthcare system. Could you maybe say a couple words comparing the American system to broadly the European system?
I think what I would say, if I could probably borrow a kind of a picture of a slide in my mind from a colleague in Germany. So we've been grappling with the demand supply issue in Europe and in different jurisdictions. It's more problematic. So in Ireland, we have a big demand supply difference, which creates significant waiting lists for patients. And that's becoming prevalent in the southern European countries. It's becoming prevalent in the UK, okay? And I describe that as a kind of a mental, social, philosophical thing that, the view from governments, from the electorate is that, you can control healthcare, the way to control it is to set a block grant, so give a hospital X amount of money on the 1st of January, and you basically say, now that's it, that's all you're going to spend. And straight away, there's a psychological, less innovative issue. On the flip side, in the UK, or in the US, what I've experienced is a fee for service model. So the notion that, you get paid for the tests that you provide, you get paid for the procedures you provide, and hence you incentivize more productivity. Now, you can't maintain the price of an ever-expanding system, but at least your the psychological incentive is to do more to meet the demand. So how do you marry? And in Germany, they've tried to marry these things to get the best of both systems, but they're a standalone, in my opinion. That is not affecting other jurisdictions such as UK, Ireland, and the southern countries. Scandinavia is a bit different in that they've attacked this with their primary care system. So the notion of keeping patients out of hospitals. And if you look at Sweden as an example, they privatized their primary care system 20 years ago. And they've managed to maintain a stable quality service that meets its demand. So but it all goes back to this, if you're in a country where the mindset is control, not incentive, you create these obstacles for yourself. And at the same time, you're dealing with the ever-expanding age, demographics, and where are you going to get the money from? So that's, I hope I've addressed that for you.
Yeah, thanks for that, Brian. Another thing, if I could, that really stood out in your presentation was at a number of points you talked about privatization. And so again, it's multiple and varied in different countries and different regions. But I'm wondering just if you could share your views on would I be correct in saying there is an increasing move towards privatization, towards private providers, private hospitals, private insurance across Europe? Is that true? And secondly, maybe to speak about that dynamic, why is that happening and what might the effect be?
So the word privatization in healthcare in Europe is a difficult word. People will use independent sector. They'll even call social insurance not privatization, but in reality, it is fueling privatization. And of course, the left side of government, or the left side of politics in Europe hates the word privatization. However, if you look at the last decade in particular, year on year, every country in Europe is seeing more and more privatization of services. And that could be as simple as, you know, a new primary care center opens on your street. It's run by a group of entrepreneurs. And for all intents and purposes, you think it's owned by the NHS. You just don't know. But the NHS has entered into a contract with private individuals who are making a profit margin, okay? So we're seeing more and more of this. We're seeing more pressure on citizens looking for other ways of accessing healthcare. So they will look to buy a health insurance policy. So there are more people taking up health insurance across Europe than before. So at every avenue, I see more and more creative ways of providing healthcare more efficiently. At the bedrock of that is privatization and incentivization. In the Irish context, you know, we have 19 private hospitals with about 2,500 inpatient beds for a population of just under 5 million people, with a fueled by a health insurance industry that generates about 12% of the overall funding from the country. So we see it here in my hospital in Beacon. I worked in the public health system for 23 years. I'm in the private health system about 6 years. We are full, completely full. The demand for our services is such that we are full. But what's happening there is that people are giving up the attempt to access the public system because it's just not there. It's just not there to the extent necessary.
Mm-hmm. And Brian, another point here from the American perspective, of course, we grapple with the cost of healthcare and with insurance and without insurance. And it's been a domestic national debate here for decades. One of the issues surrounding cost of care is the malpractice insurance that medical professionals must carry here in America due to lawsuit. And of course, this leads to this idea that if you go to see the doctor, they will tend to prescribe more tests and more diagnostics than may be necessary in order to cover themselves in case of a malpractice suit. So we see that as a major driver of costs, amongst others. Can you tell us what the European perspective is on that?
Yeah, so for those jurisdictions where private practice is prevalent and is growing, what we see on the malpractice side, so take something like spinal surgery. Yeah, you know, what we're seeing now in some jurisdictions is becoming unaffordable for doctors, and as a result, countries Ireland had to react many years ago to obstetrics because no practitioner could get private indemnity because the lawsuits were so great. In those scenarios, what we're finding is jurisdictions are stepping in and setting thresholds. So what they're saying is that if the claim exceeds, in our case, €400,000, the country will pay the gap. So the malpractice insurance company is only on the hook for the first 400,000. After that, the government central scheme kicks in. And the reason governments are doing that, without that side of the market would collapse and you have a further skew of demand supply. And that's what's happening, I see it in Europe. The governments are stepping in more and more to make it affordable for practitioners. On the supply, on the over testing, for want of a better term, we don't see that as clearly. We're not as sophisticated as the American system in counting the transactions of healthcare, if you can understand. So in Ireland, our private insurance companies, you know, pay on a fixed price procedure basis and a per diem basis. They don't get into the granularity of how many tests a patient has because there's no incentive to overtest in the hospital. There's none. They either pay on two platforms. They'll pay you a package price for a hip replacement. If you're a general medicine patient, they will pay you for the number of days you're in the hospital, not for the number of tests you've had. And they will intervene if they feel the length of stay is too high. So if a patient is in the hospital for 12 days and they think it should be 10, they'll pay for 10 days. And we will haggle over the other. So that's the way typically the insurance system in Europe and Ireland's an example of that, but that's typically the way it happens. In Germany, they very much depend on DRG, a DRG funding system, but they, as I say, they have managed to bring the two kind of fee for service and the controlling element together. Hence, their growth in expenditure has been relative single digits for many years, probably double 2 or 3% now per year at the moment.
Brian, thanks for that. I know it's late there in Dublin, and we really appreciate you coming on. So let me just pass the last word over to you if there's anything else you'd like to say to our audience.
Oh God, no, no. If you could help us with Brexit, I'd ask.
No worries. We'll help you there via your Consul General here, who's a good friend of ours and who visits Montana regularly, and who reminds us that Ireland is the last native English-speaking country in the EU. So we're helping the best we can, be assured. So thanks again, Brian.
Okay, no problem.
And thank you to all our participants this week. And just to give you a heads up, next week we've got the International Day of Peace Week, where we have peace practitioners coming to talk to us from all over the world. These are people who have been at the forefront of peace negotiations all around the world in order to stop conflict and to bring communities and societies together. It's going to be an extraordinary week because 21st September is, of course, the International Day of Peace. We'll be doing that in partnership with the U.S. Institute of Peace and our friends here at the Jeanette Rankin Peace Center. So you'll want to catch those shows next Tuesday, Wednesday, and Thursday. So until then, Brian, thank you very much for joining us today. Thanks to all the participants. Be well. See you soon.